It's just a little past 1 now. Should we start, or would you like to wait a little bit still?
Can we maybe wait another minute after?
Sure, sure, we can wait, no problem. Okay, thank you so much. Thanks all of you for coming. I think Ivy, did you want to say a word before we start?
Yes, I did. Good afternoon, everyone. My name is Ivy Castellanos, and I'm the Director of Programs with the Alzheimer's Association Hawaii chapter. We want to thank you all for joining us today. It is my absolute pleasure to introduce Dr. Kamal Masaki. Dr. Masaki is professor and chair of the Department of Geriatric Medicine at the John A. Burns School of Medicine at the University of Hawaii. I was actually prepared to share Dr. Masaki's full bio, which of course is very impressive and I think makes clear that she does not sleep. But I think you all know that Dr. Masaki is very modest and humble, and she asked us to get on with the presentation. So without further ado, I will turn things over to you, Dr. Masaki.
Ivy, thank you so much for that kind introduction. And when I end my talk, I'm actually going to introduce my colleagues from the Alzheimer's Association and hope that they may be able to answer some of your questions as well. So today my topic is healthy brain aging and dementia. And as Ivy said, I'm with the John A. Burns School of Medicine. We have a Department of Geriatric Medicine there. One of very few in the country, by the way. We are only one of 7 medical schools in the US that have a Department of Geriatric Medicine. I'm also the academic medical director for the Queen's University Medical Group. Our faculty practice merged with Queen's last year. So these are the topics I'm going to cover today. I'll talk about changes in structure and function of the brain with normal aging and ways to keep your brain healthy. Then I'll move on into dementia. I'll talk about definition, rates, subtypes, causes, risk factors, symptoms and diagnosis, and then treatments and goals of care. And I'll end with a description of some of the wonderful services that the Alzheimer's Association provides for all of us. I'm going to start my talk with a very dramatic statement. Alzheimer's disease is a public health crisis, and I truly believe that. We have almost 6 million people in the US living with this disease. It is the 6th leading cause of death across all ages. And 1 in 3 seniors dies with some type of dementia. I recently saw something that said this is now closer to 1 in 2 seniors dying with some form of dementia. So this is a very, very common problem, and it hits all of us For those of you who are associates at Kahala Nui, it'll hit your residents in IL, your patients in the nursing home and in assisted living. You actually have a memory support unit that is purely for patients like these. And in our own families, just prior to starting this talk, we were talking, so many of us, unfortunately, are affected because our family members also have this very devastating disease. I'll start with all the good news, healthy brain aging. It used to be thought that there was nothing that could be done, and this was inevitable. If it was in the cards, you couldn't do anything. And now we know differently. So this is what healthy brain aging is. This is what all of us want as we age and get older, to continue to have the ability to think, reason, and remember, to carry out our tasks and basically live our lives, function independently, keep socially connected with our family and friends, and keep our own sense of identity. But there are some changes in the aging brain, even with normal aging. We know that some parts of the brain actually shrink. And this is particularly true for the hippocampus, which is the part of the brain that's responsible for memory. And that's buried deep in our temporal lobes right over here. And we know that as people age, even with people who are completely functionally normal, this part of the brain gets a little bit smaller. And we do notice a slight decline in the ability to learn new things and to retrieve information. So remembering names, finding words, things like that can be more difficult. I've had patients who've actually gone back to college when they retired because they never had a chance to go when they were younger. And now they have a chance. So they take adult education classes. And they've told me, I can still memorize things. I can still do it. But I notice it's a lot harder than when I was 18 or 20 years old. There's also difficulty in multitasking. But it's not all bad news. Some things actually get better. So things like vocabulary and problem solving, things that I call wisdom, actually get better with aging. So it's not all bad. We do know that to maintain brain health, there are 4 big pillars. That's physical activity, social activity, mental activity, and keeping your good nutrition. Those are really important for keeping your brain healthy. And really important too is reducing risk factors for heart disease. We know that there's a huge heart-brain connection. So all of the risk factors that are bad for your heart are also bad for your brain. So I'll start out with physical activity. We know that the more active you are, the more you exercise, there's lower risk of diabetes, high blood pressure, heart disease, stroke, even depression. Physical activity also could reduce falls. And the way they think it works in the brain is it may help improve the connections between the brain cells. So it's really important for all of us to learn safe ways to exercise regularly. And always our patients, we tell them to check with their doctors before they start a really heavy exercise routine. Somebody who's a couch potato, I don't want them going out and running a marathon tomorrow, but simple things like walking can be very good for you. I'll show you some data later from our own studies here in Hawaii. Mental activity is also really important. You've heard the use it or lose it theory, right? So we want people to stay mentally active even after retirement. When people ask me, what should I do to stay mentally active? I say it really depends on the person. For some people, things like reading books or playing games or puzzles might be good. Other people like doing Sudoku or numbers. Learning new things is always important. Taking classes, volunteering is a wonderful way to stay mentally active. Now, I want you to be very careful about certain things that make these really unrealistic claims. Like I've seen books out there or puzzles out there that say, if you play this game every day, you will not get Alzheimer's. Or if you read this book, it will prevent Alzheimer's. And that's not true. Nothing has been absolutely proven to do that. Otherwise, we would all be doing it, right? But in general, we do know the more mentally active you are, the better it is for your brain. Same with social activity. Again, after retirement, that's when people fall into this trap. They just stay home and maybe watch TV all day. So it's really important for people to remain socially engaged with family and friends. And this has been associated with reduced risk for health problems, including dementia and depression. So I tell patients, go out and join senior centers, other community organizations. I have to say the pandemic has been really bad for this. Because what did we do when the pandemic first hit? We shut down everything, right? So our patients, even our IL patients, were all kind of basically isolated for a very long time. I do understand, and I still think that there are times when isolation is necessary, like when there's an outbreak. And right now, Medicare is not even allowing us to do keeping any people out, no matter what the situation. So I think the pendulum has swung too far the other way. But in general, we do know the more socially engaged people stay, the better it is for their brain as well. For nutrition, the best studies have really been done with the Mediterranean diet or versions of the Mediterranean diet. And they've shown that those diets can help reduce the risk for dementia. These are very common sense diets, lots of fruits and vegetables, whole grains, lean proteins, less of the bad stuff, less of the bad fats, the saturated fats, less sugar, less salt, and having enough liquid in your diet. And then I talked a little bit about the heart-brain connection, reducing heart disease risk factors. The top two are probably the most important, controlling high blood pressure and diabetes. So keeping your blood pressure and your sugar levels under control are super important for your brain as well. But I do want to emphasize this. These diseases usually don't start in old age. Most people start getting high blood pressure or diabetes in middle age, and then they continue to have them into old age. It's really important that we do lifelong good control of these diseases, high blood pressure and diabetes. If we wait until old age and then start to bring blood pressure, it actually could have a rebound effect. Same with the diabetes. In fact, in older, frail people in their 80s and 90s who are quite frail, I actually liberalize the diet and I keep the diabetes. I don't fight for very low sugars or very low blood pressures because it could have a paradoxical effect on the brain and it may actually cause them to fall or faint or things like that. So this control of all these risk factors is important to do as soon as these diseases are diagnosed in middle age. Having good control of high blood pressure, diabetes, high cholesterol, avoiding obesity, stopping smoking at any age, and staying physically active. All of these are very, very important. The CDC has come out with this Healthy Brain Initiative. They did this along with the Alzheimer's Association and other partners. And you can just Google it. It's a really good document, actually, if you want to download it. It's a large document, but it's kind of fun to read. And they've done a really good job with it. And this other website that I put on here is the Hawaii State Plan on Alzheimer's disease and related dementias. And I know that people from the Alzheimer's Association are on that committee, and so am I, and several of my colleagues in geriatrics. And they have different parts of this, including clinical care, education, and research. Every state has come up with their own plan on how to deal with this really devastating illness. I'll move on then to what is dementia. So before I tell you what it is, I'll tell you what it's not. There are some common myths out there. One is that memory loss is the same as senility or becoming senile, and it's inevitable with age. And this is absolutely not true. All of us know people in their 80s, 90s, and beyond who are super sharp mentally. My mom is turning 90 this year in a couple of months, and she is sharper than I swear. I mean, she is much sharper than me mentally. Physically, she's slowing down a little bit, but mentally she's staying really, really sharp, which is wonderful. Senile means old. If we say all old people get dementia, it's inevitable. That's just not true. And it's not very encouraging for old age either, is it? The second myth is that nothing can be done for dementia. And while I would agree that we do not have a cure and our treatments are not very good yet, despite that, I do believe that a lot can be done. I hope I convince you of that in this talk. The third myth is that most people don't want to know if they have dementia. And when they've done studies asking older people, if you developed dementia, would you want to know? The majority of people say yes, they would want to know, they would want to plan. So all of these misconceptions contribute to the under-recognition of dementia. These are the facts. It is not normal aging. It actually represents several types of diseases. Another fact is that it's common, it's underdiagnosed, it's a very expensive disease, and it is a fatal disease. And the third fact is that patients with dementia should have a thorough evaluation by physicians who are experienced in this condition. So the definition we use is from the Diagnostic and Statistical Manual, the DSM, which is used in psychiatry. You need to have acquired deficits. What this means is there's a change from the previous. This is not mental retardation. This is not a congenital intellectual problem that people were born with. These were people who were intellectually normal and now have a deficit. There needs to be a deficit in memory and at least one other cognitive domain. It cannot be only memory. It needs to be bad enough that it's affecting their social functioning around their family and friends. And if they're still working, it's interfering with their work performance. And we need to see an absence of delirium. Delirium is an acute confusional state that we usually see in the hospital. And it comes on really suddenly. So while somebody's in the hospital and having a delirium, you cannot make a diagnosis of dementia. You have to wait until the delirium clears. And you have to have an absence of major psychiatric disorder. So if somebody has schizophrenia that it's active or a major depression that's active right now, we have to wait for those psychiatric conditions to be treated before we say that the patient has dementia. There's also this condition called MCI, or mild cognitive impairment. This is like a pre-dementia. It's sort of a precursor. You get a subjective cognitive complaint. It could be from the patient, but more likely it's from a proxy informant. It's from a family member or a friend who notices a problem. And we see cognitive deficits on testing in at least one domain. This could be memory, language, attention, executive function, visuospatial function, any of these things. But at least one of them is abnormal on testing. But they have normal social and occupational functioning. Remember, if this was affected, they would have dementia, right? So these are people who have a complaint, usually from the proxy of family member. They have testing problems, but they're still functioning. It's sort of like a pre-dementia. And we know that these patients have a high risk of converting to Alzheimer's disease. The rate of conversion is about 12 to 15% per year. So in about 5 years, half of people will have a diagnosis of dementia. This diagnosis, this MCI diagnosis, is actually a very hot area of research right now, because half of the people convert to dementia and half don't. We're really interested in knowing, why do half not convert? What is different about them? What can we do to avoid people from converting? So again, we don't know the answers yet, but some drugs are being tried and behavioral interventions are also being done in this stage of mild cognitive impairment. Because if we could keep people at this stage where they're still functional, that would be a lot less burden for the patient, the family, and for society. So next I'll move on to how common this is. Unfortunately, very common. 13% of the population over the age of 65. And when we look at the patients over age of 85, it's almost half of patients have cognitive problems. We see a geometric increase in the prevalence of disease. So after the age of 60, the rate doubles every 5 years. And I've got a graph to show that to you. So if you look at this graph, I'll just orient you. On this axis, we have age, and it goes in 5-year age groups from 60 to 65, 70, etc., all the way up to 85. And up here is the percent who have dementia. So you can see this purple line is basically people who have a diagnosis of dementia that's affecting their functioning. And this red line includes those with MCI, or mild cognitive impairment, where they're having significant memory problems, but some of them can still function. For both these lines, you notice it's a curved line going up. It's not a straight line. That's because it doubles every 5 years. So it goes up and then doubles again, etc. So it's kind of going up at a very exponential rate. But by the time you hit 85, you see it's about 1/3 of people have dementia that's bad enough that it's meeting our research criteria and affecting functioning. And if you include the MCI, it's almost half of people over the age of 85. The reason why it goes so dramatically higher every 5 years is because there's a long duration of this disease. This is not something that kills you quickly. You can live with it for a very, very, very long time. It's a major cause of disability, and it's the primary reason for being put in an institution, in a nursing home or in a care home. In Hawaii, they've estimated that those who are there for long-term care in an ICF, for example, about 80% of them because they have dementia. And it's a very expensive disease. Actually, these numbers are a little outdated. It's closer to 300 billion now annually for care, and the same amount for lost productivity. Think about it. If you have friends and family who've had dementia, many people take early retirement or have to take time off work to be caregivers for their loved ones who have dementia. So the family is bearing a lot of the cost of dementia. Next, I'll move on to subtypes. And this next slide, this is a very, very important graph. I really want to stress this because this is such a misconception sometimes. Not all dementias are Alzheimer's disease. Dementia is the umbrella diagnosis, and under that, Alzheimer's happens to be the most common type of dementia. About 60 to 80% in the US and in many other European countries is Alzheimer's disease. And then there are other types that are less common, but all of these form the dementia syndrome. Some forms of dementia are actually reversible. We can treat them, but that's very rare, unfortunately. The vast majority of people who have dementia, it is not a reversible diagnosis. So I've had families tell me, oh, my mom has Alzheimer's, but she doesn't have dementia. Well, that doesn't make sense because Alzheimer's is one of the forms of dementia, right? So dementia, if they have Alzheimer's, they definitely have dementia. That's one of the forms. The most common, again, is Alzheimer's. If you look at this pie chart, it's about 2/3 to 3/4 or so. And then if you look at this red wedge, vascular dementia or stroke-related dementia is the second most common. And about 10 to 20% of people will have dementia that's of vascular dementia, depending on which study you look at. Then there's Lewy body dementia, Parkinson's disease. This yellow wedge is Parkinson's and all the Parkinsonian syndromes. And then the rest is mixed and other dementias. So this is what we see in white populations. Alzheimer's is very predominant. Vascular is the second most common, but not that common. And then the others are sort of trailing behind that. And I'll show you some information from our own research here in Hawaii that shows that our Asian populations in Hawaii are slightly different from the white populations. At Kokini, we've had the Honolulu Heart Program, which has been a research study which started in 1965. So it's in the 57th year of follow-up right now. It's actually the third longest running study in the whole world. It's really an amazing study. It started with 8,006 middle-aged Japanese American men in Hawaii, here on Oahu. And it actually started out as a study of heart disease and stroke. They were doing comparisons with Japan and also with Japanese Americans in the mainland US. But around 25 years after that, in the early 1990s, the National Institutes of Health, which has always funded this study, realized that now these men are older. And we have 25 years of wonderful data of heart disease risk factors. So the National Institute on Aging got involved to study dementia. So that began the Honolulu Asia Aging Study. So the heart disease and stroke was still being studied, but now the focus also shifted to include dementia. This began in 1991 in 3,734 men who were ages 71 to 93. And again, as I said, the purpose now was to study cognitive function, dementia, disability, depression, all the things that become more common with aging. So these men have had serial examinations over 50 years. And this is what we found with our rates of dementia. So let me orient you a little bit to this graph. Here on this axis down here, we have the age groups. This is in 5-year age groups again. This is 71 to 74, 75 to 79, 80 to 84, and 85 plus. And if you look at these blue bars, this is dementia that meets our research criteria. So it's affecting their functional ability. And the overall prevalence was about 9.3%. But when you include the MCI, or the mild cognitive impairment, the prevalence was about 13%. So the overall rates are similar, at least, to the US, other studies in the US in Caucasians. But when you look at the subtypes of dementia, they're a little bit different. So when you look at this highest age group, if you remember the line graph that I showed you before, about 1/3 meet criteria for dementia and almost half when you include the MCIs. This next graph, though, looks at dementia subtypes. And if you remember that pie chart that I'd showed you, where the vast majority of dementia was Alzheimer's disease, and vascular dementia or stroke-related dementia was a really small wedge. Here, you can see, again, we have the same age groups on this axis. The blue bars now represent the Alzheimer component, and the red bars is the vascular or stroke component. And you can see Alzheimer's is still most common, but vascular is not that far behind. And when you look at the rates here, in this youngest age group, the vascular dementia was actually more common. Now, after that, Alzheimer's becomes more common and definitely overtakes. It's definitely number one, especially in this oldest age group. But the ratio isn't how it was in the pie chart I showed you, right? It wasn't like just 10 to 20% is vascular dementia and 60 to 80% is Alzheimer's. Here you can see they're much closer to each other. And this has been borne out in studies from Japan, China, and Korea, where vascular or stroke-related dementia is prominent in Asian populations more so than it is in white populations. I'll move on next to Alzheimer's disease. So this was first described by Dr. Alzheimer in 1906, and he called it a pre-senile dementia. Senile means old, right? So this was actually a person, the first case that he described was a lady who was in her early 50s, very young for Alzheimer's disease. She rapidly progressed. She had very severe disease, very severe memory problems, severe psychosis, behavior problems. She progressed pretty quickly, and in a couple of years, she died. And he got her brain at autopsy, and he actually described the same changes that to this day are the hallmark of Alzheimer's disease. So we've known about this disease for over 100 years. And yet, very little research was done until I think the research really started in the 1980s. Prior to that, they used to think this is a very rare disease. And the reason I say that is because in 1900, life expectancy at birth was about 45 to 50 years. So most people died quite young. And then over the century, life expectancy almost doubled. So as life expectancy grew, and we have more and more people now living into old age, now we see this disease becoming much more common because it is clearly an aging-related disease. It is the most common cause of dementia in Western countries. Short-term memory, orientation, and problem solving or executive function are affected very early in the disease. And behavior problems are common. In some studies, 70 to even 100% of people with Alzheimer's will have behavior problems at some forms, at some time in their dementia. It's a very slow, insidious progression, but it always progresses. Everyone with Alzheimer's progresses. Most of the time, it's very slow, but it can be quick in some patients. The duration from diagnosis to death can be anywhere from 2 years to 25 and even more years, but the average is about 8 to 10 years from diagnosis to death. And this is what we see. We see changes in the chemicals in the brain. So neurochemicals, neurotransmitters, these are the chemicals that send messages between brain cells. And the chemical that's particularly low is acetylcholine, which is sort of the memory chemical. So you can imagine why patients with Alzheimer's disease, memory is a very prominent symptom, right? Memory problems. But even other neurotransmitters are affected, which is why it's not only memory, it's behavior and sleep and even movement that can be affected with Alzheimer's. In addition to these chemical problems, we see two types of abnormal proteins that are deposited in the brain. And these are microscopic views of the brain. These are abnormal proteins called beta amyloid plaques, and these are abnormal proteins called neurofibrillary tangles. And both of these are seen in Alzheimer brains. And what they do is they're basically strangling the brain cells. The brain cells or neurons are actually dying. So on the top right here, I have a picture of a normal brain at autopsy and an Alzheimer brain. You don't need a microscope to see that the Alzheimer brain is really shrunken. It is much smaller, it weighs less, and you can see that it's very different looking from the normal brain. That's the problem with Alzheimer's disease, is it's actually killing brain cells, which is why once it progresses, you cannot reverse it. These are some of the risk factors. I divide them into non-modifiable and modifiable. Unfortunately, we haven't found a cure for aging yet. So I always say age is the strongest non-modifiable risk factor for Alzheimer's disease. It is by far the strongest. And the second strongest is low education. These two, higher age and lower education, has been found in every study, in every country, in every ethnic group, in men and women. Those two are by far the two strongest. Traumatic brain injury is controversial. Some studies have found that it is linked to Alzheimer's, some have not found it. I would say in general, I would not recommend getting your brain repeatedly pummeled over and over again. I know that sounds like a ridiculous thing to say, but that's really the point of some sports, right? Is, for example, boxing. The whole point of boxing is to knock the other person out, to cause a traumatic brain injury to the other person, basically. There's been a lot of attention given to this with recent injuries with football, actually, the National Football League. They've had a lot of these NFL players who've had multiple concussions and are testing in their 20s and 30s, their cognitive tests, they're testing like they have Alzheimer's. And we know they're going to have long-term problems down the road. So there's been a lot more attention paid to this. I would not recommend those types of sports. Actually, I wish they would ban some certain sports. Genetics is, again, non-modifiable so far, but I have a whole slide on it, so I'm going to talk about it a little bit later. There are some modifiable risk factors as well. We already talked a little bit about the cardiovascular risk factors. The two most important are, again, high blood pressure and diabetes throughout your life. Dietary factors. Heavy alcohol intake, we know, is bad for the brain. So I make sure that, I recommend for normal older people that they drink, if they do drink, they drink very little. And for people who already have Alzheimer's, I recommend that they stop drinking completely. Depression can be a modifiable risk factor, chronic inflammation. Some studies have even found sleep disorders can be a risk factor, and even hearing problems can be a risk factor for development of future dementia. Moving on then to genetics, this often comes up as a question because people are worried, right? My dad had Alzheimer's, my mom had Alzheimer's, or my grandparents did. Am I at risk for it? Well, the answer is it depends. There are two major types. One is an early onset Alzheimer's. These are very dramatic. These are patients who are in their 30s, 40s, 50s. These are the ones actually they usually make movies about. It's unfortunate that they mostly make movies about this type of Alzheimer's because then everybody thinks that this is the more common type. It's actually very rare. This early onset Alzheimer's is seen less than 5% of the time. It is rare, but when you see it, it is very dramatic. You see multiple family members affected, often in the same generation and also with multiple generations. These are autosomal dominant genes. What does that mean? If you have the gene, you will 100% get this disease if you live long enough. And again, you don't have to live very long because these present in their 30s, 40s, and 50s. So far, 3 genes have been identified. We know there are more out there that we haven't identified yet. I do recommend that these patients and their families go for genetic testing and for genetic counseling. So if you ask, should we get genetic testing? Yes, I would say for the early onset Alzheimer's, I do recommend it. There is a role of Down syndrome. We know that patients who have Down syndrome, if they die in their 40s even, so that's pretty young, when they've done autopsies on those Downs adults, they found plaques and tangles in the brain in their 40s, even if they don't have dementia. So cognitively, they may be okay. They haven't declined yet. They haven't developed Alzheimer's, but they have the same lesions in their brain. And they definitely develop dementia at a much earlier age than the rest of the population. So we know there's a link with Down syndrome, but we don't know exactly what that is. Now, moving on to the rest of the patients, which is the late onset Alzheimer's. This is the most of these patients. These are the people you see who get Alzheimer's past 65, into their 60s, 70s, often into their 80s or beyond. Here, family history is a very slight risk factor, but it's not a big one. We do know that if you have Alzheimer's in your family, you're more likely to have it. But it also could be because there's more longevity in your family. We know longevity is very familial as well. So if you have more people in your family who live to extreme old age, and we know age is the strongest risk factor for Alzheimer's, you can imagine why you'll have more families with more Alzheimer's in it, because they just have a lot of older people. There's only been one gene identified so far that has been linked to the late onset Alzheimer's, and that's the apolipoprotein gene, the E gene, which is if you have the E4 version, then you may have a slightly increased risk. If you have this gene, it increases the likelihood you'll develop Alzheimer's, but it doesn't guarantee it. So you could have the E4 and not have Alzheimer's. You could not have this and still have Alzheimer's. It is not definitive. I don't recommend testing routinely for these patients. I do recommend it for the early onset Alzheimer's, okay? What about the protective factors? We talked about physical, social, and mental activity. But I have some data from our own Honolulu Asia aging study. So this was the Kokini study. We looked at walking, and we looked to see whether it was protective to develop new dementia. On this axis here, we have distance walked. So these are the people who walk the most. They walked more than 2 miles a day, 1 to 2 miles, quarter to 1, and this is the least walking, less than a quarter mile a day. And we looked 8 years down the road, what were the rates of dementia? So we looked at future dementia. And you can see the lowest rate is in the people who walk the most, and then it gets higher and higher and higher until in this low group, it's almost double the rate of the high group. This is just simple walking. And similarly, when we looked at social engagement, we looked at high, medium, low, and low. We divided them into these 4 groups. And again, those with the high social engagement had the lowest risk of dementia down the road in the future, and it got higher and higher, and it was now more than double the risk in those who had the lowest social engagement. Next, I want to talk about why early detection of dementia, I believe, is so very important. First thing is, we talked about reversible causes, right? There are some dementias that are treatable, and if you treat the person with those problems, then you can actually reverse the dementia. If you find those problems late, it's too late to fix it. So we really want to give the person the best chance they can of reversing if they do have one of those conditions. Some of those conditions include vitamin B12 deficiency, low thyroid hormone. There are a few others like that. So it's really important to find those very early and treat them. More important than that, though, because these are quite not very common, is to improve treatment of underlying conditions. Can you imagine? Let's say you have a patient who has high blood pressure and maybe emphysema, and they go to see the doctor, but the doctor doesn't know they have dementia. Their family doesn't know they have dementia. The doctor's talking to them and explaining to them what to do, what kind of exercise, what type of diet. These are the medications they're prescribing. They're describing all of this stuff. And the patient is smiling and nodding and saying, yes, doc, because in early stages of dementia, they're very socially appropriate. But when they go home, they don't remember anything. So now their high blood pressure, their diabetes, their emphysema, their congestive heart failure is not getting treated correctly, which leads to ineffective and expensive crisis-driven care. These are patients who often will end up in the ER or be hospitalized multiple times because they're not taking their medications as prescribed, or they're not doing what they're supposed to be doing for their medical conditions. The other reason for early detection is patient and family education. We want these patients to do advanced healthcare directives. We want them to do financial planning early on while they have the ability to talk to their families, to their lawyers, to communicate what their wishes might be. There are some major safety issues, and then connecting people to available community services as well. I want to show you some data about how a lot of dementia is missed. So this is again from the Kokini Honolulu Asia Aging Study. Let me orient you to this graph. This bar is people who we gave these people a very thorough research evaluation for dementia, and we feel pretty comfortable they didn't have dementia. These were people who met our research criteria for MCI, and these were people who met our research criteria for dementia. We're quite confident that they had it. And we asked their caregiver, usually it was a spouse, sometimes it was a child, an adult child, and we asked them, does Mr. X have a problem with his memory or thinking? And the answers were no problem, yes, possibly, and yes, definitely. I want you to focus on the red, which is no problem. Even those who met our research criteria for dementia, about 20% of the caregivers said no problem with memory or thinking. And when we looked at MCI, about half of them missed it. This next one is even more alarming. The same three groups, no dementia, MCI, and dementia. This time we asked the caregiver, has he been evaluated for memory problems? Again, this was unrecognized, no evaluation, or yes, they had an evaluation. I want you to again focus on the red. Among those who met our research criteria for dementia, less than 40% had an evaluation for dementia. Among the MCI, less than 5%. Remember, we want to find these problems early so we can do all these things to try and help the patient and the family. Well, we're not finding it early. This was a different study. This was done by one of my previous fellows, who's now a professor at UCSF in California. And he actually looked at a primary care practice in Hawaii. It was a group practice. And he examined the patients himself, their patients, and he also reviewed their charts to see whether or not the person had received a diagnosis of dementia. And he even asked the physicians whether they thought the patient had dementia. And these were undiagnosed dementia, okay? So these were missed dementias. Among all the patients, 67% were missed. Among the mild dementia, 90% were missed. Among moderate, half were missed. Okay, none of the severe dementias were missed, but should we be proud of that? I mean, severe dementia, even a layperson can determine, right? It's very easy to tell when somebody has severe dementia. The point is, these doctors, very good internal medicine doctors, were missing half of moderate dementia and 90% of mild dementia, 2/3 of overall dementia. So we know that, so you might say, wow, our Hawaii docs are really not doing a great job. Well, when they've done studies in the US mainland and even studies out of Australia, they found the rates of undiagnosed dementia are really high. So it's not just us, it's a lot of people. If you don't look for it, you will not find it. These are some of the symptoms. Memory loss, of course, is the hallmark. But the trick is you have to look for short-term memory loss. Long-term memory loss happens later in the disease. So I can tell you, I've seen this happen where I've seen family members say, Mom has a wonderful memory. She remembers things from my wedding, which was 40 years ago. Well, yeah, she remembers that, but she forgot what she had for lunch half an hour ago. That's the point, is the short-term memories goes first. Disorientation is common to the date or even to the place. Now, I'm not talking about when we travel. We all get lost when we travel, right? We go to a new city or a new state and we're driving or even walking and we lose our way somewhere. That's not unusual. I'm talking about somebody losing their way home from the grocery store, which is 1 mile away, and they've lived there for the last 40 years. That's the type of getting lost I mean. Difficulty with naming and understanding, and in late stages, even having a conversation can be very difficult. These patients lack insight, so they don't realize they have a problem. And this is particularly true for Alzheimer's disease. They may even have an underlying depression. So when you ask a patient with Alzheimer's, how's your memory? They will say, my memory is great, doc, because they don't even realize they have a problem. It's often the family or friends who will notice. Behavior problems are common. Personality change is very common and can be very distressing to family. Wandering can be a huge problem. All of us have heard of people who've wandered off, and some of them have never been found again. I'll talk a little bit later about some of the programs that the Alzheimer's Association provides. And at late stages, patients become socially inappropriate and show very poor judgment. Moving on then to treatment. These are the stages of cognitive function. So this is time. So this is going from normal to abnormal. And these are the phases over time. So there's a very long period, which is actually decades long, which is pre-symptomatic, where changes may be happening in the brain. We know now with functional MRI scans and with PET scans that 10 years or more before somebody presents with dementia symptoms, changes have been starting to happen in their brain already, but they don't know it. This green line is cognitive performance. This is still totally normal. And this purple line is function, activities of daily living. This is also totally normal. Next, we get into the prodromal or MCI, mild cognitive impairment phase. Here, functioning is still okay, but you can see cognitive function is not doing so well. So now on testing, you'll start to find some problems. And then once you tip over into dementia, both of them get very abnormal. We really want to catch people either here or preferably even here, so we can stop the problems and just completely X out dementia if we can. That's what the goal is down the road. So these preventive strategies, we really want to have them for the whole population. We want to recognize very early for the people at risk when they develop problems and have early diagnosis of dementia and treatment of reversible causes. Non-pharmacological strategies are important. First is we work with an interdisciplinary team. It's not just the physician. We work with our nurses, our social workers, psychologists, dietitians, rehab, etc. The whole team is important for these patients. And they need regular medical appointments. This is not somebody you say, call me when you have a problem. You really need to be seen. They need to be seen on a regular basis. Usually I would say at least every 3 to 6 months, sometimes more often. Environmental modification can be super helpful. So I've had families who told me that, oh, you know, he gets really agitated because he keeps asking me, where's the bathroom? And, you know, we've lived in this house for 20 years and how come he can't find the bathroom? And I tell them, put a picture of the toilet on the door of the bathroom. And I know that's not something you want to decorate your house with, is pictures of toilets, but at least that will give them some recognition and they won't be asking constantly about where to go. So some environmental modification can really help with some of the orientation and disorientation problems that they have. Legal planning is important for healthcare to make the healthcare directives, durable power of attorney, but also financial planning. And then care for the caregiver. This is the most difficult job in the world. So We need to monitor these caregivers with their caregiver burden, suggest respite, and then support groups. And education, community resources. The Alzheimer's Association is a wonderful resource. So is the Executive Office on Aging of the state of Hawaii. All of those places can be referred to. These are some of the FDA-approved treatments. Two major classes, the cholinesterase inhibitors, Aricept, Exelon, and Reminil-Razidine. Those are the three major drugs right now. There have been no head-to-head studies on efficacy. They're all thought to be about the same, so it really depends on the physician's preference and on side effect profile and ease of use. I will be very honest. I am very disappointed with all of these medications. So the other one is it's a different mechanism, an NMDA receptor antagonist, Memantine or Namenda. I've been very disappointed with all of them. At best, you can expect temporary stabilization or slow decline. So you really need to educate patients and families. Don't expect a cure because that's not going to happen. Some of these medications possibly reduce behavioral disturbances, so they can be helpful for that. But the biggest problem I have with those meds, remember we talked about this, right? There's chemical abnormalities. What those medications are trying to do is replace chemicals, especially acetylcholine, into the brain. But what they're doing nothing about is these abnormal proteins. And these proteins are what is killing the brain cells and leading to the shrunken brain, which has less cells. So unfortunately, they're not fixing anything with these. At best, it's a Band-Aid trying to replace some of the chemicals into the brain. So we need better than that. A new FDA-approved treatment that came about just last year was Aduhelm or aducanumab, which is a beta amyloid antibody. So what that would do is try and affect these proteins, which is these beta amyloid plaques, and actually try and prevent the shrinkage of the brain. The FDA actually really rushed this, and they approved it under the accelerated approval pathway, which is very weird. I actually look it up to see what is this. They say they provide patients with a serious disease earlier access when you expect benefit, even if you're not sure there's going to be benefit. I thought that was a very premature thing to do. And actually, since then, they've pulled this drug and it's not being used anymore. The other problems were that it was such an expensive drug. It cost $56,000 a year, and it's not a pill. You have to give it by IV infusion every 4 weeks. So I think at this point it's being reevaluated, and I hope better studies are done before they decide to approve a medication, because I thought this was really rushed. Okay, so that's all the treatments, and unfortunately, they're not very good yet, but as I said, a lot of research is being done, and I hope down the road there'll be better treatments. These are some of the safety issues we can take care of now, though, not waiting. For medications, people can forget to take medications, but even more dangerous, they can take accidental overdoses. So you have a patient with Alzheimer's, they forgot they took their blood pressure pill and they take it over and over and over and over again and end up in the ER with an accidental overdose. Over-the-counter medications can be very dangerous for patients, particularly those with Alzheimer's. I'll give you an example. Benadryl, which is a very common medication that's used for allergies, for itching, for other things. It's an anticholinergic. Well, guess which chemical is low in the brain in Alzheimer's? Acetylcholine. So now you're giving somebody who already has low acetylcholine, you're making it even lower by giving them an anticholinergic medication. So Benadryl, which makes most people sleepy, can have a paradoxical effect in a patient with Alzheimer's that can make them completely crazy. So I really don't want them to take those kinds of medications. Even cough and cold medications, sleeping medications, I really try and avoid them. I tell my patients' families, please call me before using any over-the-counter medications. Wandering, we talked about that a little bit. The Alzheimer's Association has a wonderful program called the Safe Return Program. It's a national database. Basically, you register the patient in the database, you provide an electronic photograph for their computer program, and they'll give you either a bracelet or a necklace that the patient cannot take off. It's a medical alert bracelet or necklace. And on the back of it, it says that the person is memory impaired and there's an 800 number. So even if the patient is in Las Vegas and wanders off, you can call that 800 number and start the search right away. Another benefit of being in that program is some states have a need that if you report a missing persons, there's a waiting period of 24 hours or 48 hours or even longer in some states. If they're in this program, the search will start right away. It's like an Amber Alert in a child. Leaving the stove running can cause a fire. Leaving the water running that's not quite as dangerous, but can still cause flooding and damage to the house. Driving can be a huge issue. And in general, I recommend that patients with Alzheimer's really be evaluated for their driving safety before continuing to drive. These patients are also at risk for elder abuse and neglect, including financial abuse. One of my colleagues, Dr. Tamura, who actually does come to Kahala Nui's nursing home, he did a really cool paper in Hawaii Medical Journal many years ago looking at excessive sweepstakes participation. And he did a case series and found that many of those patients had lost hundreds of thousands of dollars in sweepstakes and later were found to have an undiagnosed dementia. And wouldn't it have been better if it had been diagnosed early so that the families could take precautions? So the summary of the treatment strategies: early diagnosis is key. Treat the cause if you find it. Treat complications like behavior and sleep. Provide a safe and stable environment. Provide family education and caregiver support with a team. And provide community resources and plan for future financial and legal issues. Our goals of care are very different for patients with dementia. Our goal is not so much keeping them alive longer, but more improving quality of life and maintaining independence and function. That's what most people want. When we ask older people what's important, what matters to you, that's what they think is important. Avoiding social isolation and giving care for the caregiver. So I want to give a little plug to the Alzheimer's Association. I know we have Ivy, LJ, Tanya, all of them were there. If people have questions about for them, please do ask. They're a leading source of information on dementia. I really like their website. Please check out their website. It's on the bottom. They have caregiver classes. We work with them a lot to do those together. They have support groups for caregivers. We do trainings for community as well as for professionals. They can even help with care consultation. They have counseling services. They can help plan. They can refer patients and their families to resources for dementia evaluation. I already talked about the Safe Return program, and they have a really good clinical trials matching service. So if you have patients or families who are looking for clinical trials, they can help with that as well. So I'm going to stop here and see if anybody has any questions. Thank you all for your attention. Any questions for either me or for the Alzheimer's Association folks?
I have a question, doctor. Here at Kahala, you know that we do experience, Alzheimer's, dementia patients in independent living and of course in Hiolani. And, a lot of times it's the behavior that we have to end up dealing with, as caregivers, right? When you have someone who's either aggressive or violent, what is the best approach for caregivers?
Yeah, so, that's an excellent question, but a very complicated question. And I'm actually going to suggest that maybe you guys should ask for a whole session on that, and maybe even 2 sessions on that. 2 of my colleagues, one is Dr. Aida Wen. She does a really good presentation on non-pharmacological behavior management. So without use of meds, what kinds of strategies can you use? And then Dr. Brett Liu, who's a geriatric psychiatrist, he's another colleague of mine who does a wonderful talk on medication use for pharmacological behavior management. And maybe those are folks who you guys can call in to do these talks for your whole group. For behavior management, it is so complex and it really depends on the patient and on the situation. We really try and prefer to get away without medications if possible. So just the way you approach the patient can make a huge difference. Dorothy Colby is another person. I don't know if you all know her. She's with Hale Kuike, but she does an awesome series of presentations on different behavior management, non-pharmacological behavior management. So I would recommend bringing in those people. It's not a simple, this is not a simple answer. You need a whole hour lecture on it.
Any other questions, anybody? Well, thank you so much, Dr. Masaki. We really appreciate you taking the time to speak with us and educate us. I mean, I really learned a lot. And, it kind of helps you understand, why people act the way they do and behave the way they do. And this is very, very informative and really appreciate you taking the time.
Thank you. The biggest thing to realize is they're not doing this on purpose.
Oh, yeah.
That's the biggest thing I have to explain to family. And sometimes they'll say, I think he's doing this just to annoy me, especially a spouse, spouses, how I've been married for a long time too. So, you can kind of you love each other, but you can get on each other's nerves sometimes too, right? And so I've had spouses who've been married for 50, 60 years and he's just doing this to spite me. I'm like, no, really, he's not. And they say, well, sometimes he can do it, sometimes he can't. How come? And I explain, it's like a loose wire. Sometimes that connection is there and sometimes the connection isn't there, but he's not doing it on purpose. This is the disease talking, not the person talking. So, it can be so hurtful, right? That they're accusing the spouse of cheating. They're accusing the spouse of stealing from them or, doing various things. It's very hurtful to family members. And I have to constantly tell them, please do not take it personally because this is not him or her talking. This is the disease talking. And then we teach them strategies about how to redirect and that type of thing. But it can be very, very painful. It is not an easy job. It's very easy for me to talk about it, not easy to do the actual caregiving. And then, Tonya has put in the chat box. Let me read this for you. So she said a wonderful resource is the Alzheimer's Association 24/7 helpline number. And she's given the number, it's 808-272-3900. And they also have a presentation on understanding and responding to behaviors. That would be, if maybe LJ or Tonya or Ivy, if you guys could set that up for this group, that might be a really good presentation for them to listen to.
Yeah, we'd love to do that. If I could also, mention that this month, June, is Alzheimer's and Brain Awareness Month. So we're really trying to increase awareness out in the community about Alzheimer's and dementia. Actually, earlier today, we were at Honolulu Hale and Mayor Blangiardi declared June as Alzheimer's and Brain Awareness Month, and the Honolulu Hale will be lit purple. We do have a caregiver symposium that's coming up on June 15th. It's a half-day virtual conference. The theme this year is building resilience and lighting the path forward. So it's really this year focused on kind of, coping and healing and building foundations for self-care for caregivers. So, I'll share a flyer perhaps with Lynn, and Lynn, feel free to share it with any staff or residents who you feel might be interested.
Thank you so much. And don't forget the Alzheimer Walk every November. We usually have two teams. This year we're going to merge. Usually our medical students do a JABSOM team for the medical school, and then Queens has its own team. But this year we're going to merge and do a large team of the two groups together. So, yeah. Yes, please support these guys because they do important work that's important for all of us, our families, our community, and we really need to all work together. And thank you all for the associates. I know a lot of the work you do is taking care of patients with dementia. some of them known, some of them not known. As you said, some of your IL patients, you might have noticed things are off there. The doctor may not even have made that diagnosis yet. So yes, thank you for all you all do.
Thank you very much.
Okay, thanks again for your attention.
Thank you, doctor. That was great.
Bye.